Good morning, all of you. At the outset, I thank the Director of Public Health for giving me this opportunity, and the team of the Directorate of Public Health who have got me here to talk about the medical curriculum in the present context. At the end of this session, possibly I would like all of you to think in terms of medical education and its impact on primary health. How every primary care physician in himself is a medical teacher. The primary healthcare centers in this state and this country are classrooms of the medical college. And the future of healthcare lies in integration of the primary, secondary, and tertiary care health systems in this country. And the way forward towards that is technology-driven integration of the three services. To give a small introduction of the medical education scenario in this country, we are one of the largest medical education system in the world. And we have 695 medical colleges today with 1 lakh MBBS seats and 60,000 plus PG seats. But as a medical teacher for all these years, what worries me is, in spite of all the investments that have gone into create medical colleges and infrastructure, we are still struggling to bring out the best of students or the best of the products from these medical institutions. To go back, to look out at what the medical education system in this country was, we need to actually flip back the pages and go back to history. The allopathic medical system in this country started 400 years ago with the coming of the Portuguese, and then of course the East India Company. And we had the first medical college in this country in 1822 in Calcutta. And very interestingly, the first revolution or the first change in medical education in this country was in 1835 when Lord Macaulay changed the medium of instruction of the medical education in this country from native language to English. In 1946, we had the William Bohr Committee reforms. In 1953, what was said in the William Bohr Committee came into action, that is the introduction of the preventive and social medicine in the curriculum. We had Lakshmanaswamy Mudaliar Committee, which recommended that students need to go to the PHCs to train. We had Srivatsava Committee, which introduced a very interesting program called as the Rural Oriented Medical Education, the ROME program, which was operational for almost 10-15 years and was quite very vibrant, and somehow I think it has disappeared today. These are all issues which we need to think about, discuss, and maybe take some action on that. And coming to J.S. Bajaj Committee, he had very strong words of the medical education system where he said, the teachers are good clinicians are bad teachers. So that was when the medical education unit was introduced in the medical colleges. From 80s to 90s, if you go back in history, we find that we had a huge slump in the medical education system. There was a gap in the supply demand, and we were not producing the right kind of doctors. When we analyze the way in which the medical education system moved, we come across 4 important things. The medical education system failed to align to the rapidly changing economic scenario in the country. It was not aligned to the social priorities of the country at the time, and the national health priorities and the national public health programs did not align with the medical education system, either way, both ways. So, that alignment, the word alignment was what I was looking at, and when I looked into the references, very interestingly, we had a classical decision cascade in the government of India, which was controlling medical education. The cascade was, whenever there was a disease burden or a health problem, that spurred, along with the progress in science, that spurred the national priorities. And the priorities spurred national health program, and only after that, the thought of making changes in the medical education system rose. And the Medical Council of India took in all that, and it took its own time to create variations in the curriculum to address the requirement. So new or adjuvant curriculum was created, it was inserted into the MBBS curriculum, and doctors were created. So how exactly this was working for the last 70-80 years of our independence and post-independence era? 47 to 60, the huge medical problem we had was deaths. So the curriculum was training doctors to treat the patients to prevent death. 60s to 80s, it was lack of access causing death. So our training was focused on basic clinical knowledge and introducing curricular interventions like the Rome program, students going into the PHCs, doctors going to the PHCs and conducting one day of OP, all that was there. 80s to 2009, the accessibility of healthcare was added on with diagnostic and therapeutic capacity building for the primary healthcare and nearer to home care for the patients. There, when you see the education curriculum, the only change the curriculum had, the major change the curriculum had was community medicine curriculum was moved to the first year of medicine from the second year. Now 2009 to 2020, no major curricular change has happened? Yes, it has happened. So there are two major things which I would like to mention here is the National Health Policy of 2017 and the vision document of MCI of 2015. So let us look each one, how exactly they have tried to create some change. The National Health Policy of 2017 puts its focus on 4 areas beyond the major diseases which are part of its specific policies. Number 1, reducing inequity through affirmative action, patient-centered and quality of care for being provided to the patients to provide dignity and confidentiality, affordability as distinct from equity to reduce the catastrophic household spending, and multi-stakeholder approach to healthcare in the villages. With this, I just move into my area, that is medical education. That is the MCI vision document of 2015. These 6 are the major thrust areas which the MCI vision document talks of. Number 1, better regulatory structure, reducing regional inequity, affordable medical education, learner-centric medical education, and professionalism and ethics as a part of the curriculum, and health system interaction. Here again, I want you to think of this. The mention is about health system interaction. So, what did the MCI do after the action document came in was, number 1, for better regulatory structure, the MCI was removed and the National Medical Commission was brought in 2019. Whether it is a better structure or not a better structure, that is left to the future to judge it. Next is reducing regional inequity and affordable medical education. The Government of India went on a fast track to create more than 200 medical colleges over 2-3 years, and the number of medical colleges now have grown to 695 and the number of MBBS seats to over 100,000. Has this reduced the inequities in the system, or has it created affordable medical education? Again, is a thing which we need to judge at a later point of time. Coming to learner-centric medical education, the MCI document talked, and the NMC has brought in what is called as the competency-based medical education in 2019 again, which is now put in place in all the medical colleges in the country for undergraduate and postgraduate medical education. That talks about something like formative assessments, competencies in each of the specialties that we study. The students need to have skills, competencies as they progress through the 4.5 to 5.5 years of training. Coming to professionalism, ethics and curriculum, and the next one, 8Com was introduced again in 2019, which is an attitudes, ethics and communication training for the MBBS students. It has been introduced by certain documents. Teachers have been given minimal training, and it is now part of the curriculum. Again, this needs to be judged at a later point of time. Now coming to health system interaction, 2 major programs, that is the family adoption program and the district residency program, and brought in. These were just framework indications which were given by the NMC, which did not have any specific what you call as the instructions of how to carry out, but there were just 2-3 pages of instruction which were given. And from the government of Tamil Nadu, we have worked on it in a far more detailed fashion, and 2 detailed government orders have been created for both of these. The MCI vision document, does it suffice for what as a country we need to look for the next 20 or 30 years? That question remains unanswered even today. So at this point, I had one question. One question that was ailing me: is it the right way to look at curricular change? Are we looking at the entire curricular reforms the way it need to be? Once the disease burden comes in, a reform comes in, or a program comes in, the medical education is altered at a later point of time. So the manpower which is trained to handle the burden arrives 10 years later than the national program. So what is the use of having such a curriculum when you don't have the right person at the right time to do the right thing? So one major change also change. That is through the use of genomics, proteomics, bioinformatics, and molecular modeling. These four issues are not part of our undergraduate curriculum today. So 10 years later, when the whole world is talking about personalized medicine, my student would be a consultant somewhere, he will not understand this language. So this change has to be there in the curriculum today. Then coming to the predictive technology, again, genomics, proteomics, data analytics are which are being leveraged in the leader countries like the US and the Europe and even in China in predicting risk, predicting disease outbreaks, in predicting infectious disease pandemics. These predictive technologies are available in this country in certain research laboratories across the country. But are these part of the medical curriculum today? It is questionable. Not even a mention of these technologies are there in the textbooks. We have not told our students that these are something that you need to be aware of or you need to understand. Coming to preventive, 20 years our textbooks have about the routine in you go tell you do or physical cervical pap smear, all that has been part. But the present day science has moved ahead of it. The preventive technologies using data analytics, data mining, and disease modeling has carried the entire process faster than what we think. There has been a huge shift or a paradigm shift in the way the patients have to be looked to or the population has to be looked to. This again is missing in the undergraduate curriculum. Coming to P4, the participatory approach. This is one thing which I feel has to be part of the UG curriculum and the students have to be trained repeatedly to understand this. That is, the care of the patient is not to be split into 3 silos, the primary care, the secondary care, and the tertiary care. It has to be participatory in character, where you have the community and the NGOs also as equal important partners in the preventive and therapeutic care of patients. This involves a huge understanding of health economics and health financing. Very interestingly, the PSM or the community medicine book, which is presently the curriculum for our students, dedicates only 1 or 2 pages of it for health economics and health financing and health management. Are we producing the right kind of doctors for the health system in 2030 or beyond? And finally is the populational strategy. The old school thought is primary care sees the patient, the doctor, I don't know, I'm not making a joke. It's technically thought as that the primary care doctor doesn't know much, so he has to refer. The secondary care doctor knows not much to treat, so he has to refer. And the tertiary care doctor knows everything and he has to do everything. In this is a one-way traffic in which the health system has developed. But is it the right thing? When we look into the entire science, it is not like that. It is about identification of a disease early, confirmation of the diagnosis and treatment. Then once the confirmation and treatment part is over, this is only 30% of the science. You need to look into why the patient has had the disease. Are there more people who are having this disease? Are there more people who are at risk of having this disease? And what can be best done to prevent the risk from progressing or the disease from becoming open? So that requires analysis and conferencing and critical appraisal, which is one major gap in the health system, where the doctors of the primary, secondary, and tertiary care do not sit across a table and discuss the diseases of that district or that locality. So, third thing is prevention strategies and strategic interventions at a district level. There are a few examples, but show me one concrete area where the tertiary care, secondary care, and the primary care sat across the table created their own interventions, their own answers for the local problems. That needs to be one major change that we need to create in the health system. And that change cannot be created by GOs or government orders. That can be created only through change in the curriculum, where the student is taught that he is part of a large system where primary, secondary, and tertiary care are going to sit across, decide what the patient and the public and the population wants. So finally, this is one of the pet subjects which I have been looking at, which is called as an integrated health system. Let us think of a curriculum which rubs off the terminologies primary, secondary, and tertiary and calls itself only as a health system. And the health system is not around the hospital, but around the patient. What the patient or the population requires is what the health system is. So, the need of a specialist care or a general practice or a community nursing or a peer-led service or a home-based support, all this has to be part of a large scenario that we will build. If you need to build such a scenario 5 to 10 years later, we need to have a student who knows what it is or understands the health financing, health economics, and health management part of it to make a move when he becomes a doctor in the PHC or in a small-time hospital in another 5 years. So these are major changes which I feel the medical education scenario has to think of it. And when I got the topic of what are the health priorities and health programs which need to be aligned, I thought it is not about alignment, it's about crucial reforms. It's about crucial deep diving reforms that the medical curriculum today in this country requires. So, and finally, the P5 strategy which I've been talking about needs to be looking at reducing inequity, ensuring affordable health care, patient-centered and quality of care, promoting accountability and transparency in the health system, and improve organizational approaches in terms of taking in new knowledge as and when it comes. These should be part of the curriculum, and this has to be one major thing which has to be debated and discussed in this country over the next 5 years. At least in 5 years, we need to have a very competitive medical curriculum in this country which will give us a very good health system in future. So, to make a final push, the competency-based medical document gives 5 roles to the doctor, that is a clinician, leader, communicator, lifelong learner, and professional. I would suggest here, let us not call a leader, because leadership is a slightly narrow term. Let us look at the doctor we produce as a health system manager. The MBBS student needs to come out and become a manager for a local health system. So let us add on to his curriculum certain aspects of health economics and health management, basic communication skills, some bit of understanding of data analytics, and of course training in technology use in primary care. With these words, I just have something more to say, that is, the oldest medical system in the world has to make efforts towards improving medical education, and hence it is a matter of time that we will reach there. Thank you so much.
So, thank you, sir. Thank you for your extensive session on evolution of allopathic system, the reforms that happened in the medical education, the problem areas that existed over the years, the experiences in aligning medical education to the health needs of the population, and an overview on MCI vision document 2015 and aligning priorities, the emerging national health problems, and the P5 strategies and the way forward. The house is now open for discussion.
Sir, morning, sir. Sir.
Yeah.
Sir, in public health cadre of Tamil Nadu, around we have 160 public health specialists, sir.
166.
162 public health specialists, sir.
166.
Okay, sir.
Yeah.
Whereas, sir, in government medical colleges, we have around 320, 330 public health specialists in the teaching post of community medicine departments. Yes. My question is, sir, how to effectively utilize the public health specialists in the teaching post of medical colleges to deliver effectively the public health programs in the field?
Maybe that is what exactly what I was mentioning here. When I use the word integrated health system, do not look at only the faculty in the public health department in the, PSM department or community medicine department in the medical college. What about the doctors who are in the medicine, surgery, OG, pediatrics? All these people have a community responsibility and they also have to come out onto the field. The primary health care and the tertiary health care are now operating in separate silos. Though in Tamil Nadu, all these doctors are from a single stream, but the moment you become an assistant professor in a medical college, you feel that you are genetically something different from the doctor in a PhD. Right? So that kind of a separation that comes into the system is creating not a convergence of thought, but a divergence of thought, which we have seen in a lot of examples around the state. When I say integrated health system, we are looking at a point where the problem of the medical college hospital and the problem of the primary health care settings move closer, and the doctors in the PHC as well as in the medical college sit together to solve the problem. It is not about leveraging the resources. Leveraging the resources is something like a HR approach to the problem. Here, what I am looking at is a convergence of objectives. See, the primary health care is not a different kind of objective to tertiary care. The tertiary care and they have to converge. That's exactly what I meant. Yeah. Is it?
Yes, sir, before DME remarks, I want to give you remarks because this has been already discussed with Dr. Shantaram earlier when I was in medical college and also with our director. And I have been telling that, I am just reflecting what you said. The medical college faculties, just because they are working in DME, or the deputy directors or the health officers, just because they are working in DPH, they are not different people.
Yes.
They are all doctors first. And all are community doctors, as you rightly said. There may be a policy where now, after 40 or 50 years, after we separated our community medicine department from DME to DPH and DPH to DME, now people are happy in one way. But when putting in this practice into curriculum, the community medicine faculties are not having any, probably in future, they will not have any exposure in the field. Yes. And similarly, what happens in the medical curriculum is not being told to the public health specialists. Yes. So there may be a policy change where, depending upon the cadre, there can be an exchange program within DME and DPH.
Yeah, in the short term, rather than when I was talking
not
in terms of
permanently.
NMC curricular change. But in the short term, till the NMC curricular change arrives, as state health systems, we can sit down, discuss and bring some kind of a convergence rather than waiting for NMC to do everything. So that is possible.
Only if you change the department, people are worried. But if you don't change the department, don't change the person from the department, but for a temporary period, we can always have an exchange programs.
Yes.
See, answering your question is very simple. You all DDs are professors and assistant professors, simply.
Yes.
We are doctors, we have to update our knowledge. That is the aim of our DPH. We have to update the knowledge. Anything, it should be communicated to the audience, patient. And even, I will put it as a simple thing. See, we are treating individual, but you are treating masses. வீட்டுக்கு ஒரு ஆள் வந்தால் சமையல் பண்ணி நாங்கள் போடுறோம். நீங்கள் 100 பேர் வந்தாலும் 1000 பேர் வந்தாலும் சமையல் பண்ணி போடுறீங்க. In turn, you are treating the masses is very difficult. So you are more than that. So you have to think that you have to update the knowledge, and you think that you are a teacher. That is the main thing of the, I think, DPH has come to this.
Agreed, sir.
Yeah.
When you are planning to put up this district residency program and...
So district residency program, already the process is on. There are only 2 postings, that's SPM and microbiology. They're just waiting for response from your office. I think Somasundaram is discussing with my office, sir.
It's fully authorized to take a call.
Yes, sir. Yes, sir. It's already discussing. There are the 2 postings which are waiting. So it will be launched from 1st January 2024. There will be availability of doctors of all, PGs of all specialty in almost 70 to 80% of the DMS side hospitals and some DPH resources all around the year, during every year, from 2024 onwards, there will be a free supply. And then the
Family
next
adoption?
Yes, sir. Family adoption, I think the GO is awaiting some financial sanctions from the TNHSRP. Once that comes in, I think we will have to train the public health doctors as well as the medical college doctors also. And that will give us a huge leverage to around 13 lakhs population as a cluster cohort, sir.
Yeah.
That
Thanks
will be
for-
one major
I should
integration.
personally thank him for the initiative taken. Good.
That will be a huge integration of the public health
Dr.
system and
Shantaraman,
medical education, sir.
I think you have made already a policy note and waiting for the GO.
Yes, sir.
And only thing we have to include the private medical colleges also.
No, it's all, we are involving 70 medical colleges in the state, even private medical colleges, even in DRP program as well as family adoption, the private and the public hospitals are all involved, same way.
Just like we have PHCs attached to the medical colleges by a GO, the villages should also be attached to the medical colleges through a GO. That also we can.
Yeah, that's already part of the FAP. Okay. Right. So thank you so much.
Sir,
Yeah, please.
Sir, actually vector-borne diseases are major public health problem still existing in our country. Still at times it has an epidemic proportion also, and some of the emerging vector-borne diseases also coming. So understanding the vector-borne diseases and entomology by the medical students, at least at the basic level, is very, very essential.
Yes.
But at present, the NMC not recommended lecturer in LME in medical colleges.
Yes.
But once it is removed from the medical colleges, that category, definitely the understanding of vector-borne diseases by the students in the future will be nil. So when they come out to the primary health care, they cannot be able to manage any of the disease control, especially the vector-borne disease. So I request the DME to recommend the NMC to include the entomologist in the medical college.
Yes. It was available. An entomology person was available in the medical college till late 1990s. The NMC removed that post and the entomologists have been shifted to the public health DD office. But as such, even now in many of the public medical colleges, entomology training is happening. The district entomologists come to the medical college and do classes. Still it's happening in many of the medical colleges. And the issue about entomology training is classroom education does not help. Actually, they need to do a field education. That's exactly where the major gap lies. Classroom teaching in community medicine or classroom teaching about community science, medical science, cannot happen in a classroom. It has to happen in the field. So that has to happen, and that requires a lot of
Sir, one more
change.
thing. See, you rightly pointed out that community medicine should not be taught in the classroom. It's well said. See, previously that professors and nursing professors were posted from the DPS side, those who are having a rich experience and field experience. While they are taking a class, they will be telling their experience to students, and at the same time, that their colleagues will be there in the district as a DDHS, district health officer. There will be a good coordination between them. But now, it's up to you.
I think I will take a dive in a slide.
But now we are telling
I think
we need it's not a classroom. We
No,
agree.
see,
we agree with that.
Yeah.
But you people only telling like that. It's up to you. Please decide.
Yeah.
Sir, added to what DPH OSD said, I have already received 2 calls from medical colleges. I don't want to mention the names, but in the interest of the students, with the permission of the director, we are planning to lend some slides, malarial slides, and also some vector-borne disease slides to the medical college because they said the malaria problem is getting slowed down and there are no cases and our students have no slides to read. This is what, and particularly,
No, that's what.
particularly the accreditation of lab, it requires slides. So probably this, all these policy
No,
changes
see,
will.
that's what the heart and soul of medical education is getting far separated from what is the public truth. The student is not taught to go and see JSB smear. The competency has changed. That's exactly. See, that is what is worrisome.
Sir,
Yeah.
thank you.
Thank you, sir.
If you permit, we'll continue the discussion.
In a private.
Yes.
Now I kindly request Additional Director of
Thank you.
Public Health and Preventive Medicine, Dr. Somasundaram sir, to honor the speaker.